Welcome back to the Deep Dive. Today, we are tackling a subject that I think for a lot of people outside the profession, it might just sound, I don't know, dry, purely administrative.
Oh, for sure.
But if you are in the thick of it, if you are a pharmacy student or a recent grad, this topic is the stuff of nightmares. We are talking about the gatekeepers.
The final boss battle.
Exactly, the final boss battle. Today, we are cracking the code of the Pennsylvania MPJE.
The Multistate Pharmacy Jurisprudence examination. It doesn't exactly roll off the tongue, does it?
Not at all.
But you are absolutely right to call it a boss battle. It is, I would argue, the most critical and definitely the most misunderstood hurdle between getting that PharmD degree and actually getting a license to practice.
It's so funny you say misunderstood. I was digging into the forums, specifically the Annapolis prep communities on Reddit, and there's this myth that prevails. You spend 4, 5, 6 years in pharmacy school, grinding through OChem, pharmacology, learning how to keep people alive in the ICU. And the story everyone tells is the hard part is over.
Right. You slayed the dragon.
Yeah. The clinical exam, the Nepalake X, that's the dragon, and the law exam. Oh, that's just a formality.
Just a little paperwork.
Just read the book a couple of times and you'll be fine.
And that advice is so dangerous. It is precisely why we are seeing what I can only describe as a bloodbath in the testing centers right now.
A bloodbath is the right word.
Yeah.
The statistics we found they're startling. So our mission today is pretty clear. We aren't just going to read law books to you. I mean, that would be excruciating for everyone.
Nobody wants that.
We're going to perform an autopsy on this exam. We really need to figure out why people are failing, specifically in Pennsylvania, and decode the methodology. We have to talk about how to study, what to study, and the specific mental frameworks you need to survive this thing.
That's the key. We have to shift the listener's mindset from being a clinician to, for a few hours, being a lawyer. Because you have brilliant candidates, people who can calculate complex vancomycin in their sleep.
Top of their class.
Top of their class, walking out of this exam in tears because they approached it with the completely wrong toolkit.
Let's lay out the sources we're using for this deep dive. We've pulled from the Pennsylvania Pharmacy Act itself. That's Act 699, which is, the bedrock.
The foundation for everything.
We've got the NABP competency statements, which is kind of the blueprint. We have these deep threads from Reddit, these support communities sharing their, I guess you'd call them war stories.
Real-world experiences, yeah.
And we're looking at the specific review guides that everyone talks about. You see the names everywhere, Dr. C's and RX Prep. Plus, and this is critical, we have to talk about the new legislation. Act 77, Act 140. Those are total game changers.
Absolutely. The landscape has changed so much in just the last couple of years. If you're using an old guide, you are walking into a trap.
Okay, so before we even get into statutes, let's talk about the panic. Because the numbers you pulled on pass rates, for a professional licensing exam, they are honestly shocking.
They are trending in the wrong direction, and it's happening fast.
Yeah.
If you look at the data from the NABP, that's the National Association of Boards of Pharmacy for graduates from ACP-accredited programs, your standard rigorous pharmacy schools, back in 2019, the first-time pass rate was about 84%.
84%. Okay, that feels right. That's a study hard, you'll probably pass kind of number. It feels tough, but fair.
Exactly. It's what you'd expect. But fast forward to 2023, that number has dropped to 74%.
Wow. A 10% drop.
A full 10% drop in just 4 years.
Let's put that in perspective for a second. That means 1 in 4. 1 in every 4 qualified, highly educated pharmacy graduates is walking into that testing center and failing on their first try.
Think about that. You're sitting in a study group with 3 of your friends. You've all gone through the same classes, the same rotations. Statistically, one of you isn't getting a license that month.
That creates a massive amount of psychological pressure. It's immense.
It is, and the job offers are often contingent on passing these boards. So it's not just about a score, it's about starting your career.
And the immediate assumption from the outside might be, oh, the students are getting lazier or the schools are failing. But is that really true, or is the test just fundamentally different now?
I think it's a combination of factors. The test hasn't necessarily become harder in a vacuum, but the law itself, the body of knowledge, has absolutely become more complex. We have so many more regulations now than we did in 2019.
Right.
And the testing mechanism itself, the software, has become incredibly sophisticated at finding your specific weak spots.
Okay, let's break that down. The mechanism, because this isn't a paper and pencil Scantron test like the SATs.
Not even close.
This is what we're calling the beast. What actually happens when you sit down at that computer?
You're walking into what is essentially a marathon of focus. The exam itself is 120 questions, but here is the first mind game. And this is so crucial to understand for your own sanity when you're in there. Only 100 of those questions actually count toward your score.
So the other 20 are, what, ghosts? They're just there to mess with you.
They're pre-test items. The board is basically beta testing them on you. They want to see if a question is valid for future exams. Is it too confusing? Is it too easy? Is it worded poorly?
But you, the test taker, have absolutely no way of knowing which is which.
None. Zero. You have no idea if the question on your screen is for your score or for their data.
So you could be staring at a question that is totally out of left field. Something about, I don't know, nuclear pharmacy labeling that you've never seen in your life.
Right.
You start sweating bullets. You start hyperventilating, thinking, I'm going to fail because of this one question.
And that question might not even count. But here's the trap. If you let that one weird question rattle you, if you carry that anxiety and that self-doubt into the next question, which probably does count, you've lost. You've let the ghost question beat you.
So you have to treat every single screen as if your license depends on it. But you have to emotionally detach from the result of each one the second you click next.
That is the mental discipline required. It is incredibly hard to do.
And that's made even harder because of the CK system.
Right.
Computerized adaptive testing.
This is where the panic trap really comes into play. The C system is designed to find your breaking point. It's not trying to see if you know the basics. It wants to determine your maximum level of competency.
Okay, what does that mean in practice?
So the algorithm is watching you. If you answer a question correctly, the next question you get is statistically likely to be harder. It's a more difficult concept, a more nuanced situation.
So it's constantly ramping up the difficulty.
And if you get that one right, it gets harder again. It just keeps climbing this ladder of difficulty until you start missing them. Once you start missing, it might ease up a bit to find your consistent level of knowledge.
Okay, so let's play this out. If I'm sitting there 2 hours in and I feel like I am getting absolutely pummeled, every question feels like I'm guessing between two almost identical answers, and my brain is just melting.
That is actually a very, very good sign.
It feels like failure, though.
It feels like abject failure. But what it usually means is that you are passing. It means you are consistently answering the questions correctly, so the computer is throwing the kitchen sink at you. It's trying to see how deep your knowledge goes. It's pushing you to the absolute ceiling of your ability.
So on the flip side, if I'm sitting there breezing through it, thinking, wow, I am a genius. These are so easy. I've got this in the bag.
You should be very, very worried.
Really?
Yes. If the questions feel simplistic or if you feel like you're saying the same concepts over and over again, it often means you are stuck in the lower competency bracket. The computer has determined you can't handle the hard stuff, so it's just feeding you basic questions to see if you can even pass the minimum threshold. You're bouncing along the bottom.
That is so twisted. So feeling terrible is good, and feeling great is bad.
Generally speaking, that's the paradox of the MPJE. The Reddit threads are just full of people who walked out in tears, absolutely convinced they failed, only to get that pass email a week later.
And the opposite, I assume. People who thought it was a cakewalk and failed.
And those are the most shocking failures, the ones who had no idea they were even in trouble.
Let's talk about the scoring for a second. It used to be you got a number, right? Like, I got an 82.
Yes, that changed back in 2021. Now it is strictly pass-fail. You simply get a result, no numeric score.
Which I guess takes some of the pressure off trying to get a perfect score, but it adds this other pressure of just not knowing where the line is. What about retakes? If you fall into that 26% who fail.
This is where it gets tricky, and there's a lot of misinformation out there. The general rule from the NABP is that they allow you to take the exam up to 5 times per jurisdiction.
Per jurisdiction, so per state.
Correct. So you get 5 shots in Pennsylvania, 5 shots in New York, and so on. But Pennsylvania has historically been stricter.
How so?
There's a rule, and we see this in the support groups where people are panicking about it, that Pennsylvania essentially has a 3-strike rule within a certain time frame, usually 2 years.
3 strikes. What happens then?
If you fail 3 times within that 2-year window, the board may require you to complete a specific learning plan or some kind of remediation before they'll even let you try again.
Ouch. So you really, really want to knock this out in the first or at worst the second attempt. You do not want to be staring down the barrel of a state-mandated learning plan.
Exactly. It delays your career. It costs more money, and it's incredibly demoralizing. You are essentially put in the penalty box by the Board of Pharmacy.
Okay, so what exactly are they testing? What is the blueprint for this beast?
The NABP breaks it down into 4 main competency areas. And knowing the weight of these areas is critical for prioritizing your study time. You can't just read the law book cover to cover and hope for the best.
You need a strategy.
You need a strategy. The 2 biggest chunks are pharmacy, pharmacist practice, and medication use process. Combined, they make up over 60% of the exam.
Over 60%. So break those down for me. What is pharmacy practice in this context?
That's your identity as a professional. It's all about who can do what. What is a pharmacist legally allowed to do versus what can an intern do versus what can a technician do? It covers licensure requirements, continuing education, scope of practice, all the rules that govern the people.
And medication use process.
That's the journey of the prescription itself. From the moment the doctor writes the script, is it a valid prescription? Does it have all the required elements? Is it a controlled substance?
All the way through to dispensing.
Exactly. It covers drug utilization review, or DUR, patient counseling requirements, documentation rules, generic substitution, every step in that chain. If you master those 2 sections, you're more than halfway there.
And the other 2 sections are dispensing requirements and pharmacy operations.
Right. Dispensing requirements is about the physical product labeling, packaging, rules on returning drugs. And pharmacy operations is the business side, record keeping, security, inventory management, who needs to be on site. They're about 20-24% each.
So you can't ignore them.
You can, but if you don't know who is allowed to take a verbal prescription or what a valid C2 prescription looks like, you will absolutely fail. The big buckets come first.
That brings us perfectly to the next big idea, the mental shift.
Yeah.
You mentioned earlier that clinical thinking is poison on this exam. How do we train our brains to think like a lawyer for 2.5 hours?
This is, without a doubt, the single biggest hurdle for students, especially for students who have worked in pharmacies for years as interns or technicians. We call it the workplace trap.
The workplace trap. I saw this phrase all over the research. The number 1 piece of advice was, don't answer based on what you do at CVS.
Precisely. Because large chain pharmacies, your CVS, your Walgreens, your Rite Aid, they often have corporate policies that are significantly stricter than the actual state law. And there's a good reason for that.
Liability.
It's all about liability. They're massive corporations, and they want to minimize risk across thousands of stores. So they create policies that are easy to enforce and that give them the most legal protection.
Can you give me a really concrete example of that?
Sure. A really common one is medication returns. Let's say a patient comes in with a sealed, unopened bottle of medication. They say, my doctor changed my dose, I don't need these.
Happens all the time.
All the time. Now, your corporate policy at big chain pharmacy might be an ironclad, no returns accepted, ever, under any circumstances. It's just easier that way. It avoids any possible risk of adulteration or fraud.
Right. Keeps things clean and simple for the staff.
But the law in Pennsylvania might actually have a different answer. The law might allow for returns in very specific, very narrow circumstances. Perhaps if it's in the original sealed manufacturer container and it's going to be disposed of properly, not redispensed. Or if it's from a specific type of facility like a nursing home where the chain of custody was never broken.
So if the exam asks a question like, under Pennsylvania law, is a pharmacy ever permitted to take back a dispensed medication? And you answer no because that's what your boss told you.
You get the question wrong. The exam tests the minimum legal standard. It's asking, what does the law allow, not what is best practice or what is corporate policy.
So you literally have to unlearn your job to pass the test.
In a sense, yes. You have to build a wall in your mind. This compartment is for what I do at my job to not get fired, and this other separate compartment is for what do the compiled statutes of the Commonwealth of Pennsylvania say.
That's a huge distinction. Then there's the other big rule, which you mentioned, the stricter law rule. This seems like the golden rule of pharmacy law.
It is the golden rule. You have to understand that pharmacy is regulated at 2 levels simultaneously. You have the federal government, the FDA, and the DEA making rules for the whole country.
Right.
And then you have the state government, the Pennsylvania Board of Pharmacy making rules specifically for Pennsylvania, and often their rules overlap or address the same topic.
And sometimes they conflict.
Constantly. The rule you must live by is this. You must always follow the law that is stricter.
Okay, lay it out for me with a clear example.
Let's talk about prescription expiration dates.
Yeah.
Let's say federal law says a prescription for a non-controlled drug is valid for 12 months from the date it was written.
Okay, 1 year.
But let's say a hypothetical Pennsylvania law says, No. For patient safety, we think all non-controlled prescriptions should expire after 6 months.
So you've got federal at 12 months, state at 6 months.
Right. Which one do you follow? You have to follow the 6-month state law. Because by following the stricter 6-month rule, you are automatically also in compliance with the looser 12-month federal rule.
Right, because 6 is less than 12. You're covered.
You're covered. But if you followed the federal law and filled it at month 10, you would be breaking Pennsylvania state law.
That makes perfect sense. The stricter law covers both bases.
But here's where it gets really interesting, and where students can lose points. Sometimes the federal law is the stricter one.
So you can't just get lazy and memorize PA always wins or state is always stricter.
No, absolutely not. You have to know both, compare them in your head for that specific situation, and then pick the tighter leash. For example, with controlled substances, the federal DEA rules are usually incredibly strict.
Right.
If Pennsylvania had a weirdly loose rule about, say, labeling for Schedule II drugs, which they don't, but hypothetically, you would still have to follow the very strict federal DEA requirements.
So you need this mental Venn diagram running at all times on the exam.
Always. For every question involving a rule, you are asking, what does the DFDA say, what does the PA board say, and which one is tighter?
Now let's talk about words. The wording trap. I love this because as a word nerd, it's fascinating, but I can see how it would be absolutely infuriating on a high-stakes test.
Oh, it is.
The difference between dispense and administer.
This distinction is massive. It's fundamental. In casual everyday conversation, we might say, the nurse dispensed the Tylenol to the patient. In the world of pharmacy law, that sentence could describe a crime.
Whoa. Okay. Explain that.
Dispense has a very specific multi-part legal definition. It means the process of interpreting a prescription order, preparing the drug, packaging it, labeling it, and providing it to a patient or their agent for later use.
For later use, that's a key part.
It's the key part. It's the process that results in the patient walking away with that amber vial to take the medication at home.
And administer.
Administer means the direct application of a single dose of a drug to the patient's body, giving an injection, putting drops in an eye, watching a patient swallow a pill right there in the clinic. It's for immediate use.
So when a pharmacist gives a flu shot,
they are administering a drug. They are not, in that moment, dispensing it in the traditional legal sense of handing over a vial for home use.
why does this one verb choice matter so much for the test?
Because the laws governing dispensing are in a different section of the Pharmacy Act than the laws governing administration. The license required to dispense is different from the authorization required to administer injectables. The rules for who can do what are completely different.
So a question might ask, can a pharmacy technician dispense a controlled substance versus can a pharmacy technician administer a controlled substance? And those are two totally different legal questions.
Two completely different worlds, legally speaking. And if you just skim the question and your brain just reads it as, give the drug, you're toast. You have to read the verb. The verb is half the battle.
Okay, so we know we need to be paranoid about verbs and things like a strict legalist. Let's move to segment 3, the arsenal. What are we actually using to study? Because the market is flooded with prep materials, and I'm sure a lot of it is junk.
There is a lot of junk out there, and I think relying on the wrong material is one of the fastest ways to fail. Based on our source analysis, and this is a really strong consensus from successful test takers in PA, there is one undisputed champion for the Pennsylvania-specific content.
Drum roll, please.
It's Dr. C's ultimate Pennsylvania MPJE review.
Dr. C's. I saw this name everywhere. It's almost like a legend in the forums. Why is this one specific book so beloved?
I think it comes down to its format and its focus. First, the small things. It's spiral bound, which sounds trivial. But when you are studying for weeks, being able to lay a book flat on your desk without it snapping shut, it matters.
It's a quality of life thing.
It is. But more importantly, Dr. C doesn't just copy and paste the law statutes, which are written in dense legalese. He breaks them down into digestible study tips.
Like little nuggets of information.
Exactly. The book has something like 100 specific numbered study tips that highlight the most tested and most confusing concepts. And, crucially, it includes a practice exam that users consistently say actually mirrors the difficulty and the tricky wording of the real test.
So it's not just a knowledge dump, it's a test-taking tool.
Precisely. We saw multiple reports, people saying things like, I failed with other methods, then I bought Dr. C's. I read it twice and I passed.
That's a powerful endorsement. And that phrase, reading it twice, seems to be the mantra.
It's all about repetition. The first pass through the book is for familiarity. You're just trying to get the lay of the land. The second pass is for mastering the details. That's when you make your flashcards and drill the specifics.
But Dr. C's is just for the state stuff, right? That's only a piece of the puzzle. What about the feds?
Correct. Dr. C's is your Pennsylvania Bible for federal law, and you have to remember, this is the backbone of all controlled substance regulation in the country. The consensus choice is RX Prep's federal law summary.
RX Prep is a huge name in board prep in general for the NAPLX too.
They are the industry leader. Their federal summary is concise, it's accurate, and it covers all the FDA and DEA mandates that will make up a good 20 to 30% of your exam.
So you can't just ignore federal law.
You cannot. I'll say it again. If you only study Pennsylvania law, you will fail the federal questions and you will fail the exam. You have to have a dedicated federal resource.
What about supplementary tools? I saw mentions of things like TLDR Pharmacy.
Too long, didn't read. It's a great name.
It is.
Their state cheat sheets are excellent for that side-by-side comparison we were talking about earlier. They put the federal rule in one column and the PA rule in the other. It's a fantastic visual aid for mastering the stricter law rule.
So it's a good review tool, but maybe not your primary source.
Exactly. Great for a final review in the days before the test.
I also saw mixed reviews for a resource called MPJE Made Easy.
Yeah, the reviews are mixed. Some people find it helpful for getting extra practice questions. If you've exhausted the questions in Dr. C's and RX Prep and you just want more reps, it can be a good source for a question bank. But most people seem to find it's not as comprehensive or as focused as Dr. C's for the core content.
And then there are the official sources, the actual PDFs from the government website.
You have to look at them. This is non-negotiable. You need to go to the PA State Board of Pharmacy website and download the Pharmacy Act and the Pharmacist Guide.
Why? If Dr. C's is so good, why do I need to read the dense legal text?
Because review books are printed at a specific point in time. Legislation moves fast. If a new law about PBMs or technician duties passed last month, Dr. C's print edition might not have that update yet. The examiners love to test on the newest changes to the law because it proves you are current.
So you need to be actively checking for updates on the board website.
Yes. Look for sections labeled announcements, notices, or recent law changes. That's where you find the cutting-edge stuff that might not be in any review book yet.
So the strategy consensus seems to be, don't buy 10 different books and overwhelm yourself.
Please don't. That leads to paralysis.
Pick one main state book, which is Dr. C's, one main federal book, like RX Prep, maybe one supplementary tool for review or questions, and use the official board website for the very latest updates.
That's the winning formula. Pick your weapons and master them.
Okay, let's get into the deep end. Segment 4, Pennsylvania specifics. This is the stuff that trips people up, the need-to-know content. What makes Pennsylvania unique or particularly tricky?
Let's start with one of the most unique aspects of PA pharmacy law, personnel ratios.
The pharmacist to technician ratio.
Exactly. In many states, the law is very explicit. It will say a pharmacist may supervise no more than 3 technicians or 4 or whatever the number is. It's a hard fixed number.
1 to 3. Simple to remember.
Pennsylvania says not so fast. PA uses what's called a judgment-based model.
A judgment-based model. What on earth does that mean?
It means there is no fixed ratio number written into the statute. The law says that the pharmacist manager, that's the person legally in charge of that specific pharmacy, is responsible for determining how many technicians they can safely and effectively supervise at one time.
Wait. So a manager could theoretically say, you know what? I'm feeling good today. I can supervise 10 people.
Theoretically, yes. But here is the massive trap in that line of thinking. The law also says that if a significant error occurs and the Board of Pharmacy investigates and determines it was because of inadequate supervision,
the manager's on the hook.
The pharmacist manager is personally and professionally liable. So the state gives you the rope, but it's up to you not to hang yourself with it.
That's a fascinating approach. It shifts the burden of regulation from a line in a book to the professional's own judgment.
It does. It respects your professional judgment, but it harshly punishes your hubris. It essentially says, you're the professional, you decide. But if you're wrong, it's on you.
That is a huge burden of responsibility. And speaking of technicians, there's a huge change coming with Act 140. This seems to be a big deal.
Yes, this is a major modernization of the law. Historically, pharmacy technicians in PA didn't have to be registered or certified in the same formal way they do in many other states. The system was a bit looser.
Right.
Act 140 changes all of that. Effective in the 2025-2026 timeframe, the final rollout dates are being finalized. Pharmacy technicians will be required to be registered with the state board, they'll have to complete criminal background checks, and they'll need to undergo specific approved training programs.
So no more just hiring someone off the street, giving them a lab coat, and putting them behind the counter on day one.
That era is ending. And for the exam, you absolutely need to know the scope of duties. What can a registered tech do versus what they can't do? For example, a classic PA question. Can a pharmacy technician take a verbal prescription?
A verbal meaning the doctor calls it into the pharmacy.
Correct. Imagine it's 5 p.m., the pharmacy is slammed with customers, the phone is ringing off the hook. It's a doctor calling in a new amoxicillin script for a sick kid. The pharmacy technician cannot legally take that order.
But a pharmacy intern can.
A pharmacy intern can, under the direct supervision of the pharmacist. That is a critical distinction and a very common test question.
What else can't techs do?
They cannot perform a DUR, a drug utilization review. That is a clinical judgment. A tech can't look at a patient's profile and say, oh, this new blood pressure pill might interact with that other one, but I think it's okay. That is exclusively the job of the pharmacist or an intern under their supervision.
Okay, let's shift gears to the high-risk zone. Controlled substances. Let's start with Schedule 2, the heavy stuff. Oxycodone, Adderall, fentanyl.
PA follows the strict federal guidelines here for the most part, but you need to know these rules cold. For Schedule 2 prescriptions, 0 refills, period. End of story.
What if the doctor writes 1 refill on the script?
That part of the prescription is invalid. You can fill the original quantity, but the authorization for a refill is legally void. You ignore it. And the prescription itself is only valid for 6 months from the date it was issued.
6 months. So if a patient brings in a C2 script that's 7 months old, it's garbage.
It's a piece of paper. It has no legal standing as a prescription.
What about transfers? This comes up all the time. If I drop my Adderall script at CVS, but they're out of stock, can they call the Walgreens across the street and transfer it?
Historically, the answer was an absolute, unequivocal no. Schedule 2 prescriptions could not be transferred, period. However, this is one of those critical check the updates areas. There is a major push to align state laws with new federal DEA regulations that do allow for the one-time transfer of electronic, unfilled original prescriptions. But for exam purposes, unless a question specifies this new electronic exception, the default answer is that C2s stay where they land.
Got it. Assume the old, stricter rule unless told otherwise. What about Schedule 3 through V? Things like Tylenol with codeine, Xanax, Ambien.
For these, the rule you need to memorize is 5 refills or 6 months, whichever comes first.
So even if the doctor writes refill PRN for a year, meaning refill as needed for a year.
It doesn't matter. The prescription legally expires in 6 months from the date written, and even within those 6 months, you can only refill it a maximum of 5 times.
And transfers for those. Can you move a Xanax prescription?
Yes, but only on a one-time basis between 2 pharmacies that don't share a common database.
What does that mean, share a common database?
That's an exception for chain pharmacies. 2 CVS stores in the same city are linked electronically. They share a real-time online database. Between those 2 stores, you could theoretically transfer that prescription back and forth up to the number of refills remaining. But if you're transferring from a CVS to an independent pharmacy, one time, and that's it. The prescription is now owned by the new pharmacy.
That's a really important distinction. Let's talk about the PDMP, the Prescription Drug Monitoring Program. This is the big state database for tracking opioids and other controlled substances.
Yes, it's one of the most important tools we have for fighting the opioid epidemic. And for the MPJE, the single most important detail you need to memorize is the reporting time frame.
Okay, what is it?
Dispensers in Pennsylvania must report the dispensing data to the PDMP within 1 business day.
1 business day. Not weekly, not at the end of the month.
It is practically immediate. If you dispense a Percocet prescription on a Tuesday afternoon, the state needs to know about it by the close of business on Wednesday.
Why so fast?
Because people who are diverting drugs or doctor shopping move incredibly fast. If pharmacies only reported weekly, an addict could hit 5 different doctors and 5 different pharmacies in that time, and no one would know until it was too late. The one-day rule allows the system to catch suspicious activity almost in real time.
Let's move to prescribing authority. This is always a puzzle, figuring out who can write for what.
Right. You have your standard MDs and DOs who have broad authority. But the nuance and where the test questions live is with the mid-level practitioners. In PA, that's mainly certified registered nurse practitioners or CRNPs and physician assistants or PAs.
Can they write for anything? Can a PA prescribe OxyContin?
They have broad authority, but it is often tied to a collaborating practice agreement they have with a supervising physician. For the exam, you need to know that they can prescribe Schedule II substances, but there are often limitations. For example, a PA might only be able to prescribe an initial 72-hour supply of a C2 for acute pain, and then the physician has to co-sign or issue any further prescriptions. The rules can be very specific.
And then you have other prescribers with very limited scopes, like optometrists, eye doctors.
Exactly. They have a very specific set of prescribing rules in PA tied to whether they have a T license for therapeutic agents or a G license for glaucoma. The key takeaway is you need to know that an optometrist is not going to be prescribing blood pressure medication. Their prescribing has to be relevant to treating the eye.
So it's about scope of practice.
It's all about scope of practice. If you see a prescription on the exam from a podiatrist, a foot doctor for birth control pills, that prescription is invalid on its face. It is clearly outside their scope of practice.
Okay, let's talk about the brand new stuff. The recent legislative updates that old books might miss. Act 77. This is the PBM reform.
This is huge for the actual business of pharmacy, and the board wants to see that you're aware of it. Act 77, passed in 2024, puts new regulations on pharmacy benefit managers.
The middlemen.
The infamous middlemen who negotiate drug prices between manufacturers and insurance plans. The new law focuses on transparency. It bans a practice called steering.
What's steering?
That's where a PBM, who often owns their own mail order or specialty pharmacy, tries to force a patient to use their pharmacy instead of the patient's local pharmacy of choice. Act 77 prohibits that. It also bans clawbacks.
Clawbacks. That sounds ominous.
It is. A clawback is when a PBM retroactively takes money back from a pharmacy weeks or months after a prescription was filled because of some obscure contractual term. Act 77 is an attempt to level the playing field. For the exam, you don't need to be a political expert on PBMs, but you do need to know that these new regulations on steering and clawbacks exist, effective late 2024 and into 2025.
What about immunizations? Any recent changes there?
Yes, in September of 2025, there was a big update to the Pharmacists Authority. The board officially approved the immunization guidelines from ACOG, the American College of Obstetricians and Gynecologists,
Okay.
the AAP, the American Academy of Pediatrics, and the AAFP, the American Academy of Family Physicians, as being competent authorities for pharmacists to follow.
What does that mean in practical terms?
It expands and solidifies the framework for pharmacist-led immunizations. Instead of relying solely on, say, the CDC's ACIP guidelines, pharmacists can now administer vaccines consistent with the standards of these other major medical organizations. It really cements the pharmacist's role as a primary immunizer for all age groups, following the best available medical advice.
Got it. Okay, segment 5. The future. We are looking at a potentially massive shift on the horizon in 2026. The Uniform MPJE.
This is the NABP's big attempt to solve the license portability problem. As you know, right now, if you are a pharmacist licensed in Pennsylvania and you want to move and get a license in New York and New Jersey, you have to take 3 completely different law exams.
Which is a total nightmare.
It's a huge barrier to mobility. So the Uniform MPJE, or UMPJE, is an effort to create a core law exam based on universal principles of pharmacy law that apply across most states.
So it tests things that are common everywhere. Less, what is the specific font size required on a prescription label in Pennsylvania? And more, what are the general legal requirements for a valid prescription?
That's the idea, exactly. A standardized federal law-heavy exam with a much smaller state-specific component, or maybe even a separate, shorter state exam.
And this is a huge, but what about the people listening to us right now? The class of 2025? Or people studying for a retake?
This is critical. If you are taking the test in 2025 or even in early 2026, you are almost certainly still taking the current PA-specific MPJE. Do not start studying for the uniform exam. It doesn't exist for you yet.
So stick to Dr. C's. Stick to the PA specifics we've been talking about.
Yes. It is incredibly dangerous to gamble on a future format. Until the Pennsylvania Board of Pharmacy officially announces that they have adopted the UMPJE and gives a start date, you must assume that the strict, quirky, state-specific rules still apply in full force.
But it's something to keep an eye on. If you happen to fail and have to retake in late 2026, the entire game might have changed by then.
It might. But for now, prepare for the beast as it currently exists.
Okay, let's wrap up with segment 6, practical exam day advice.
Yeah.
Let's save some lives here with some final tips. First off, the rescore. You fail, and you get an option to pay for a rescore.
Don't do it.
Just flat out don't.
It is a waste of money. It costs $200, and NABP itself admits that they almost never change a result. All a rescore does is verify that the computer added up the points correctly. That's it. It does not reevaluate whether your answer was actually right or if the question was fair.
So it's basically a $200 donation to the NABP's server maintenance fund.
Essentially. If you fail, you need to accept it, wait the mandatory 30-day period, and figure out what you need to study harder.
And 30 days is the waiting period before you can sit for it again.
Yes, and you need to use those 30 days very, very wisely.
So what's the ideal study plan for those 30 days or for the first timer?
You need 2 to 4 weeks of dedicated study. And I mean dedicated, not studying with Netflix on in the background, focused, active studying.
And that mantra again. Read Dr. C's fully, at least twice.
There's that twice recommendation again. It works. The first pass for understanding, the second for memorization. And here's a key strategy tip. Take the practice exam after you have studied, not before.
That seems logical, but a lot of people do the opposite. They take it first to get a baseline.
And it's a strategic mistake. You don't know anything yet, so of course you'll fail the practice exam. All that does is cause panic and self-doubt, and you've wasted your one and only good benchmark tool. Study the material thoroughly first. Then, a few days before the real test, use the practice exam to gauge your readiness and find your last-minute weak spots.
One last specific detail that I saw mentioned in the Reddit threads was about compounding, specifically questions about low-risk versus medium-risk compounding.
Yes, this is a great point. Pennsylvania's state regulations often defer to the federal USP standards for sterile and non-sterile compounding. You need to have a basic knowledge of the USP chapter definitions for risk levels. If the exam asks you a question about the requirements for medium risk compounding, don't waste time looking for a specific PA statute. The answer is going to be based on the USP standard.
So USP 795 and 797 are absolutely fair game.
100%. They are part of practicing pharmacy anywhere in the U.S., including PA.
Okay, we have covered a massive amount of ground. Let's try to summarize the winning formula here.
To pass the Pennsylvania MPJE, it really comes down to 3 things. 1, the right materials, get Dr. C's for the state content, and a solid resource like RX Prep for the federal laws. Don't cheap out and don't get overwhelmed with too many sources.
Okay, materials first.
2, the right mindset. You have to constantly apply the stricter law rule. You have to avoid the workplace trap. You have to think like a lawyer who is looking for the minimum legal requirement, not like a good employee following corporate policy.
And 3.
3 is an obsessive attention to detail. Verbs matter. Dispense versus administer. Know the ratios, know the timelines, 1 business day, 6 months. The details are where they separate the people who pass from the people who fail.
And a little reassurance for the learner out there who might be feeling overwhelmed right now.
The test is designed to be hard. That drop in pass rates isn't because students are getting less smart. It's because the body of law is genuinely getting more complex. All these new acts, new immunization protocols, there is simply more to know now than there was 5 years ago. But it is absolutely passable. People pass it every single day. You just have to give the exam the respect its difficulty deserves.
Okay, so this is where it gets really interesting for me, thinking about the future. With this big shift to the Uniform MPJE plan for 2026, we are clearly moving towards standardization in pharmacy law.
Which, on the surface, is great for efficiency and for pharmacists who want to move between states.
Of course. But here's the provocative thought I want to leave our listeners with. Are we moving toward a world where pharmacy law becomes so standardized, so homogenized, that we actually lose touch with local needs?
What do you mean by that?
Well, take Pennsylvania's judgment-based technician ratio. That's a unique law. It's built on the idea of respecting the individual pharmacist's professional discretion. It's not a one-size-fits-all number from a national committee.
That's true. It places the responsibility on the professional on-site.
So, if we move to a national standard where, say, the rule is just 1 to 4 everywhere, do we lose that professional autonomy? Do we lose the ability for a state board to create a rule that's specifically tailored to the challenges and patient populations of Pennsylvania? Do we just become another cog in a standardized national machine?
That is the fundamental trade-off, isn't it? Standardization versus local nuance. We would gain license portability, which is a huge win for the workforce. But we might lose the specific protections and the professional philosophies that individual state boards have built over decades for their specific communities. It's a really interesting question.
Something to mull over while you're memorizing those CC refill limits.
Indeed.
To everyone listening,
Yeah.
Go get Dr. C's, watch your verbs, and do not let that adaptive computer panic you. You've got this. Go conquer the code.